Dear colleagues,
Okay,
now
differential diagnosis. Okay, radiation structure. Yes.
we arrived at the third one, Radiuscar. I hope I already convinced you about the enormous benefit of 3D histopathology. If you thought that breast cancer was a very heterogeneous disease, but cancer mimicking lesions, fibrocystic change with and without calcifications, fibroadenoma, sclerosing adenomas and fibrocystic change, radioscar, papilloma, they really give us such a hard time. It's not the cancer that causes much of a problem for you. Ruling out the cancer, that's a problem. Everywhere in the world, they say it's a false positive mammogram. What are you talking about, false positive mammogram? I see a radiating structure. I have to call her back. I have to do the procedures. And eventually, it turns out to be a non-malignant radial scar. I'm happy. The patient is happy. Everybody is happy. Don't call it false positive. Once upon a time, in the mid-80s, there was a colleague, Dr. Hughes, in England. His pupils convinced him to write a book. And he wrote a book about NDs. And that's all the hyperplastic breast changes. So this is a synonym, ND. It's aberration of the normal proliferation and involution. This is the story. In the middle of the menstrual cycle, the TDLUs are up at arms and they just call the neighbor and say, "You're not allowed to sleep. She might be pregnant. We are going to go to work, all right?" There is every month a proliferation and pregnancy is not that frequent. So there will be an involution. They don't learn the lesson. Next month they get equally excited and equally disappointed and excited and disappointed. And that's what he wanted to say. Proliferation and involution. Something may go wrong. What can go wrong? Let's do it together. And then you are going to understand all hyperplastic breast changes. Most of the breast cancers originate from the TDLU, and most of the hyperplastic breast changes and these originate from the TDLU. Some of them from the ducts, and only one from the connective tissue. What's the name of it? When the concave contoured, homogeneous, ground glass-like fibrosis proliferates and becomes convex contoured, that's called the connective tissue proliferates. PASH, here it is, stromal hyperplasia. Pseudo angiomatous. Oh, what a name. Stromal hyperplasia. PASH. Totally benign. Let's go then to the TDLU. During this exercise, proliferation, involution, the cells in the acini suddenly start to be a little bit too busy. They shoot over the mark. They produce too much fluid. And the finger in your rubber gloves becomes cystically dilated. And they can never go back to normal rubber glove. Now, you see, this is a proliferation. The end result is ND, aberration. And of course, unfortunately, we are in trouble because there is fibrosis around it. So it's called fibrocystic change. What if among the fingers there is this very delicate functional connective tissue, intralobular connective tissue, starts to proliferate and proliferates and proliferates to the extent that there will be a tumor. And at this time point, you know, Latin always, benign or malignant, ends a tumor with oma. And because we know that this is the gland, so it's actually the gland, adenoma. When the Latin connects two words, first word always ends with O. Yeah, but we know as well what proliferates. Dear colleagues, we got a fibroadenoma. So what is a fibroadenoma? I have a great suggestion for you. Whenever you talk about hyperplastic breast changes, and your student or friend or whoever, relatives, you visit them and say, one of our family members got a fibroadenoma, could you tell us what that is? And then you would say, it's one of the hyperplastic breast changes where the intralobular connective tissue proliferates to the extent that it becomes a tumor. Totally benign. Excuse me, can I get a cancer of that? Well, theoretically, yes, because you see the fingers are entrapped in this. Here are the cells. Yes, but don't worry about that, because whenever cancer develops within a fibroadenoma, it's practically always LCIS, lobular cancer in situ, or grade 1 cancer in situ. During my 40 or 50-year experience, I only saw one grade 3 carcinoma, so forget it. What about adenosis? What is adenosis? Excuse me, would you mind telling me what adenosis is? Adenosis is one of the hyperplastic breast changes, TDLU hyperplasia, and becomes larger. Instead of having 60 fingers now, the TDLU has 160, 120 fingers. So it's more hyperplasia, larger hypertrophy. Adenosis. You can add an adjective. If the intralobular connective tissue proliferates and simply strangles the proliferating acini, then the strangling adenosis or sclerosing adenosis develops. What is sclerosing adenosis? One of the hyperplastic breast changes where the TDLU proliferates and becomes larger, plus the intralobular connective tissue proliferates, and unfortunately on the mammogram, this is going to be seen, if it's seen, as powdery calcifications. But then, of course, there is other term, blunt duct adenosis. Imagine that here is your thumb, and beside it grows another thumb. You see these funny-looking acini. Both of them have one mammographic correlation, powdery calcifications. Here are the powdery calcifications. So now we are done with the TDLU, we go for the duct. Out of the duct, what kind of hyperplastic breast change can develop? Radiuscar. What is Radiuscar? Radiuscar is one of the hyperplastic breast changes where the ducts proliferate and are arranged in a radiating fashion, having a tiny fibroelastic core. Its mammographic image is this. This is going to be the black star. But basically, it's a duct proliferation. This is a benign neoductgenesis. You see the duct here? Thick, like my finger, not Eiffel Towers. And there is a huge discrepancy between the size of the radiating structure and the very tiny, if any, central fibroelastic core. There is only one more thing left, dear colleagues, and also that one originates from the major ducts, not from the TDLU. And that is called papilloma, living in the major duct. And you do galactography, of which we talked so much about. And then this filling defect is going to be the papilloma. I really talk you out of doing core biopsy because there is a satellite, and there is a satellite, there is one, and so on. So we radiologists cannot see all of them. Dear colleagues, does it make sense for you? This is such a very important cupboard full of coat hangers, and you can put one of your case to one coat hanger and the other one to another coat hanger. And so the NDs can be distributed according to what they produce, fluid or tissue. The fibrocystic change is the most frequent. The cysts are always extremely sharply outlined. But the problem is that it's called fibrocystic change. Now tell me, is this a cancer? Well, that's your first thought, right? Therefore, ultrasound was a godsend. No problem nowadays. Now, this fluid doesn't go away. It's called stagnation. What's happening with stagnating fluid? Always calcifies. So this is within a TDLU, right? And they vary in size and density, and they are very close to each other. Of course, you are thinking about grade 2 cancer in situ within the TDLU. What about fibroadenoma? Well, when it's fresh, newly born, then you are not going to find it because this is a 20-some-year-old or late teens disease when there is a lot of normal fibrogranular tissue around them. But then she ages, and then if you're smart, you start to invite her for screening. Now, at that time, this is already 20 years old. So it starts to shrink. And of course, it causes a problem. And shrinking means that there is hyalinization. So that interlobular connective tissue starts to hyalinize, which means no blood supply. So there will be these cross-stone-like calcifications. Whoops, here is another contender to grade 2 cancer in situ within the TDLU. And of course, the third one, although doesn't originate from the TDLU, same thing, papilloma. So dear colleagues, when the cancer originates in the TDLU, distance one acinus and the other one and the other one and the other one, still about just 4 or 5 millimeters, like any of these. And here is the necrosis in the middle. And if we are lucky, then we got exactly these kind of calcifications. Therefore, I call the cluster, cross-stone-like pleomorphic calcification, a joker. Because you can put your money on that this is going to be malignant type calcification, and you put the needle in, and the pathology says, yeah, how boring, fibrocystic change, fibroadenoma, papilloma. So don't speculate. Put the needle in. Fortunately, we have so many tools in our toolbox. And then the calcifications, adenosis, simple adenosis is pattern 4. That's the only high-risk patient. People say that a woman with dense breast runs a high risk of getting a breast cancer. Now, it's pretty much of a nonsense, is it? Because 40 to 50% of all your patients have dense breast. Whichever method you are classifying according to ours or BI-RADS, this one is not a high risk. That's a young woman's fibroglandular tissue that is waiting for producing milk. Normal risk. This one is another joker. I don't know what's under it. Maybe high-risk tissue, may not be. Most of the times it's not. This is pattern 5, very, very dense tissue. That's not high risk either. This one, the adenosis pattern, simple adenosis, that's the high risk. Only 12% of the population. Now that makes much more sense. Don't tell me that every second woman sitting in this class or walking in the street runs a high risk of getting a breast cancer. No. And then we have the Radiuscar. Do you see the heterogeneity here? These are the cysts. I photographed at the Phoenician in Phoenix. This is fibrocystic change. You see the yellow background and sclerosing adenosis with calcifications, without calcifications, and the normal pleated duct. Dear colleagues, at last, we are here at the Radiuscar. What is Radiuscar? One of the hyperplastic breast changes where the ducts proliferate and they are arranged in a radiating fashion. Where does this funny name come from? Well, I have to mention 2 names. To begin with, Dr. Humperl. He was a German pathologist, and he called it Strahliger Narben, which is Radiuscar. I'm not sure it's a very smart name because people misunderstand the word scar. They are looking for trauma. Dear colleagues, no, this is a spontaneous event. So John Azzopardi, who used to be the chief of pathology at Hammersmith Hospital in London, came up with a more complicated but perfect term. He called it sclerosing, ductal, look how good it is, hyperplasia. Here is the duct system, and subsegmental, and here are the TDLUs at the periphery. So while most of the cancers originate from here and not from the major ducts, in this case, the proliferation takes place here in the ducts, like a cactus. Side branches. So far, so good. Parallel with this, there is elastic tissue proliferation around them. And that's exactly what he meant, sclerosing. That's why the radiologist can see it, because this, the blue I'm drawing, is going to be radio-opaque on a mammogram. And why do you call it a black star? Because the content has some kind of a lipid material, so it's going to be radiolucent. You see in front of you a black star? Yes. So why should I bother? Why should I take it out? There is no cell proliferation, there is no cancer here. Now hold it for a second. If there is cell proliferation, it happens at the periphery, here. And your surgeon is going to take out just this one and leaves the cancer behind. I have to cool down everybody about all hyperplastic breast changes, Radiuscar included. Fortunately, DAB is not associated with fibroadenoma, papilloma, adenosis, fibrocystic change, and so on. Keep this in mind. Do you remember in DAB, in the duct, the normal cells suddenly became grade 3 cells? It's a one-step proliferation. That was the DAB. But you know, in the lobules, in the fingers, there are many steps, and here is the step wedge. This is normal. And then there are pathologists who can see ductal hyperplasia. Now, this is already a mistake because that's an acinus, okay? And lobular hyperplasia, no atypia. And now we take the next step and they say atypical ductal hyperplasia, atypical lobular hyperplasia. Can you imagine? Both of them are within an acinus and they call it ductal. Anyway, then lobular cancer in situ, grade 1, grade 2, cancer in situ, once again called DCIS, but not acinar adenocarcinoma of the breast. And of course, on the top of it, there are the invasive cancers, but these are the very good AABs. The tubular carcinoma, the well-differentiated AAB, the moderately differentiated AAB. Everybody says, oh, this is high risk. No, it's not. You're not allowed to scare the patient, please. But the teaching point is manifold. One, for the radiologist. You are so trigger happy. Give me the core. Are you going to hit this one? Of course not, because you don't even see it. Should you use core biopsy in architectural distortion that might be radial scar? No, you should not. But then your surgeon says, I'm not going to operate without core biopsy. Okay, sure. In an intelligent team, you can work out the following. We have a gentleman's agreement. I do the core biopsy, and if it does not show malignancy, you operate. If it shows malignancy, you operate. So it's always a friction between the radiologist and the surgeons. Listen, I didn't find out these things. I'm just making a fantastic, easy to understand structure of the NDs. I'm going to show you so many cases. Sometimes we did core biopsy. Why? Because sometimes there is unusually large central fibroelastic core, and your ultrasound says this is cancer. Then you are forgiven. But I understand the poor surgeon too, because in order to take out the Radiuscar, he has to operate the periphery as well. And he is not willing to, because of cosmesis. Sit back, relax. I'm going to entertain you with pictures you have never seen in your life. 3D histopathology. One of the hyperplastic breast changes where the ducts proliferate and they are arranged in a radiating fashion. I'm going to show you stereo pictures, which you're not going to see in stereo, but if you had the stereoscopic glasses in front of you, can you imagine these ducts would come towards you, go away from you, they go right and left. Sit back, I'm going to show you quite many cases. Look at this. And of course, these proliferating ducts, some of them may be dilated cystically. Look how many ducts. Now you understand that there is a fibroelastic core and there is a radiating structure, which is going to be a black star. I'm going to show you pretty soon. Shorter ducts, longer ducts, whatnot. Look at this beauty. Look at one after the other. Now, mind you, these may be associated with cancer. What do you mean cancer? It may be associated with epithelial instability. Now you should think about the step wedge. That's epithelial instability, a little bit of atypia. You show it to two pathologists and you got three different answers. Relax your shoulders. It's not a killing cancer you are going to miss. This one is full of carcinoma in the middle. This one doesn't have any epithelial instability because you see the radiating structure is totally empty. And this is empty too. And count on some cysts when you do the ultrasound. And on ultrasound, you can make the diagnosis. Too much fibrosis. Isn't that beautiful? Look at this. Skinny ducts, distended duct. I'm so happy that I collected this for you. And nobody in the world has it. And actually we wrote 11 3D books. But number 10, volume 10 is missing because I didn't have time to write the Radiuscar. That's supposed to be volume 10, supposed to be the Radiuscar. You see the pleated ducts here? And people think that this is kind of cicatrix that is shrinking into, oh, come on now. That's a desk product. That's ridiculous. This is an active proliferation of the duct, one of the four basic building blocks. And therefore, you can imagine, fresh radial scar may be positive on MR. But burned out radial scars may be negative on MR. So hyperplastic breast changes are always tricking you. You see some cell proliferation with the cribriform pattern here. And this one, the pathologist signed out as Radiuscar. It is not. This is a DAB. Look at the cancer cells all the way. In every branch, this is neoductgenesis. Get this, disorderly. This is the malignant neoductgenesis. What is coming after this is a very quick test for you. You got 2.5 seconds to decide whether it's a white star or whether this is a black star. Actually, if they are very typical, then the distinction is not that difficult. Still, all of them has to go to surgery. Why? Because depending on whose article you're reading, in 10 to 40% of the cases, there may be something on the step wedge. Somebody calls it cancer. But it's at AAB, so don't worry. Comfort the patient. So, and I'm going to show you an article. The colleagues were shooting core biopsy on 40-some cases, and in 9 cases missed the cancer.
Thank you very much, Professor Laszlo Tabar, for these elaborated lectures. And now with our dear colleague and dear friend, Dr. Jessica Lowe, she will give us a talk about inflammation.